Hello, everyone. My name is Michelle. Thank you very much for joining us. Today, we are extremely fortunate to host Richelle, Flanagan, and Annelien Oosterbaan, who will be talking to us about being in the shoes of a woman living with Parkinson's. This is an important topic that is very often overlooked. Richelle is a registered dietitian and was diagnosed with young onset PD shortly after the birth of her second child. And Annelien is a gynecologist and was diagnosed with young onset PD 7 years ago. She's a proud mother of 4 children. I'm not going to go into the detail of this, but both are extremely active Parkinson's disease advocates. And as you will see tonight, they have a wealth of experience to share with us. Before we start, I would like to remind everyone, like I do always, that this session is for information and education purposes only. So if you're seeking medical advice, diagnosis, or treatment, you should really consult a medical professional. There will be time for questions at the end of the presentation. And if you want to ask a question anytime, please use the Q&A function at the bottom of your screen. I'm asking everyone to not put the questions in the chat function, as we will not see them, but put them in the Q&A function at the bottom of your screen. So for those of you who don't know us yet, No Silver Bullet is managed by Mark Lambert and myself with the aim of sharing Parkinson's expertise. We really aim to help you and frankly to motivate you to become well-informed generalists in your condition in order to make informed choices on how to adapt your lifestyle, to manage your symptoms, and hopefully to slow down disease progression. For that purpose, we are organizing Zoom sessions like today's with researchers and PD specialists to update you on the latest advances in science and medicine, nutrition, exercise, wellness, and even technology. We post the recordings of our sessions on YouTube and on Spotify, and we also post short videos on TikTok and on Instagram. The details for those different media are available on the chat in the chat section at the bottom of your screen, as well as on our website. Our website is nosilverbullet4pd.com, nosilverbullet4pd.com. But let's come back to today's topic and to Richelle and Annelien, who will be talking to us about being in the shoes of a woman living with Parkinson's. Annelien, you're going first, I believe. The stage is yours.
Thank you. And thank you for inviting us to share our knowledge on this topic and our experiences. Let me share my screen with you. You see, my computer is quite slow. Can you see my presentation well? It's about being in the shoes of a woman living with Parkinson's. Well, I am a woman living with Parkinson's. I also am a former gynecologist. Now I'm a senior researcher on the project Women and Parkinson's Disease, and also, of course, a person living with Parkinson's. And I call myself a Park influencer lately as well. The day I got diagnosed, it was December 1st, 2016. Being a young woman, 33 years old, it was quite awkward to get this diagnosis because it really didn't fit my identity or the way I felt. And the reactions people gave me when I told them I had Parkinson's were also not quite nice, or they all said Parkinson's, but isn't that an old man's disease? So I kind of felt forced into an old man's suit. And then still these days, it's 2023, when you Google, you fill in Google Images, Parkinson's patient, this is what you see. You only see the images of a shaking old men instead of also women. So I thought it was time to get rid of this ancient image of the shaking old men and kick him out. Because Parkinson's also occurs in women, and the ratio of men versus women is like 60 to 40%. Even I, as a doctor, I didn't know this. We didn't get this information at medical school. I thought maybe it was like 80-20 or 70-30, but it's almost equal. So there are many women living with Parkinson's disease as well. And yeah, there's just a giant gender gap in research up till today. Women are highly underrepresented in scientific papers and men-dominated clinical trials. That's also due to up to the 1990s, we just weren't allowed to join clinical trials. And therefore, the treatment of men is the same as the treatment of women. We get treated like we are small men, but we simply aren't, just small men. So hello to the side effects. Of course, for me, it's like common sense. Even the rats and mice in research are male, just to remind you. And of course, there are gender differences because we are genetically different, hormonal differences between men and women. And happily, there is increased interest in differences between men and women in medicine in the last years. This is growing, this interest, and also in neurological disease. And we think there's an important role here for estrogen, the female sex hormone. And the question is, does it have potential protective qualities? Well, let's talk a little bit about the menstrual cycle. Because having menstrual cycles as a woman is already hard. Like sometimes in the month, I can feel like, damn, I feel like a woman. It's not so nice, but being a woman with YOPD is even worse. So help. I noticed a cyclic pattern in my Parkinson symptoms. And this perimenstrual worsening of Parkinsonian symptoms may be due to estrogen withdrawal. And here you can see the menstrual cycle from week 1 to week 4. And week 1, that's the week that you have your period. So day 1 is the first day of your menstruation. And then here you can see all these sex hormones, and the estrogen drops in the middle of the cycle. And then by the end, and the new period, when the new period comes, it will rise again. Since I noticed it's a cyclic pattern in my symptoms, and no one around me, not my gynecologist, not even Bas Bloem, could help me with answers, we set up a research program at the Radboud UMC for women and Parkinson's disease. And the research questions and topics are based on this own lived experience and stories of other women. We did a Dutch survey on the hormonal impact and also psychosocial impact of PD in women below 60. And we set up a PracSpark registry, but I will get back to that later. Our survey design is, we asked women in the Netherlands between 21 and 60 years old who had a diagnosis of Parkinson's disease. And we wanted to explore the influence of hormonal fluctuations on Parkinson's disease and also their experience with their healthcare providers. And it was a one-time online survey, and some women got interviewed as well. Some of the results, of course, it's small groups because it's only the Netherlands, but still, this hasn't been done before. It's like an increase in PD symptoms around the period in 66% of women, so at least 2/3 of women. And I think it's even more because we had women with oral contraceptive pill menstruating and also natural cycle. So when you only look at the women with a natural cycle, not taking contraceptive pills, the numbers are even higher. They go up to 80%. And almost all the women had these increase in severity of PD symptoms in the week before their next period, so just before the next period starts. They reported a lack of energy, anxiety problems wearing off, so less effectivity of their Parkinson medication, and also a more rigidity. So these were the symptoms most mentioned to deteriorate by the women. And then we asked whether they had discussed this topic with their healthcare provider, and it was 42% of women who were assertive to talk about this topic with their healthcare provider, and they all had to bring up this topic themselves. So no neurologist asked for it. Previously, also PD Avengers did a great survey in 200 women in the UK and Ireland, or Richelle. And they, it goes too fast. And they also found approximately 80% of worsening of PD symptoms in women. And they asked also about the neurologist engagement on this topic. And they found that 12% of neurologists ever asked about the hormonal impact on their Parkinson's. And in our survey, only one neurologist ever asked, but it was a neurologist who asked for a hormonal impact in a woman with already in the menopause, but no one asked about the cyclic pattern. Women have shared their experiences with us, and their doctor either had never heard of the topic or has ever heard of it, but rarely, and has no idea what to advise or to say, or dares to say that they believe it's all in their head. So it's not there. This is what we saw this week, and Richelle and I were kind of excited about this paper, even though it's a really small group, but there's a new paper out from an Italian group and they have looked at premenstrual worsening of UPDRS scores in women affected by Parkinson's disease, and they wanted to really show this the role of estrogen in dopaminergic pathways. And they have followed like 9 women with a regular menstrual cycle, and they were followed up for 4 months, and 3 full menstrual cycles. They had UPDRS scores done by a neurologist who was unaware of the cycle phase of the woman. So they just came to the clinic every week, and the neurologist didn't know what the time phase was. And the women had to complete surveys to rule out the diagnosis of PMS. And then the cycle was divided into phases, the menstruate, so day 2 to 6, follicular, early luteal, and a late luteal phase. And then eventually they were able to show an increase in UPDRS scores, a premenstrual increase in UPDRS scores. And this confirms the role of estrogen in dopaminergic pathways. Did they also look at the estrogen in the blood, the estrogen levels, or no, not Richelle? I don't remember. But at least the UPDRS scores were higher. So this confirms this role of estrogen, and the abrupt reduction of estrogen levels during the perimenstrual period may contribute to reduced responsiveness to dopaminergic treatment during menses. So I think, and I always advise women to get like a hormonal treatment and not use more dopamine or levodopa in these days, because it's just not effective. So I think we should tackle this with hormonal treatments or hormonal advice. So you should visit a gynecologist. And at the Radboud, we now collaborate with a gynecologist who sees women for us. And I think that's the way to go. I think, that's the way to help women, best help women. Of course, now we don't know what to do yet. I think maybe an oral contraceptive pill and a continuous, so take it daily without stopping. But we have to find this out in the future. But still, this is a nice paper, and I'm happy with it. Another life stage is, of course, a pregnancy. Well, I can tell you a lot about pregnancy and what we know, but we don't know that much yet about pregnancy and Parkinson's disease. I've been pregnant with Parkinson's 2 years ago, so my daughter is now 1.5 years old. I've dived into literature to find out what we know and what we don't know. And the literature describes a 50% of women deteriorating from pregnancy and 50% doesn't. So it's just a big guess. It's like deciding to become pregnant again, like with already having 3 healthy children, but still for any woman with Parkinson's disease is just a really tough decision, because you don't know what is going to happen or what to expect. Levodopa treatment seems to be safe. We are told we cannot breastfeed, but of course, that's just because we don't know whether it's safe or not. So then we just are told we shouldn't. So yeah, for me, it was a tough decision, but still we decided to go for it because yeah, when you have the wish to have a child, it's just a really big wish. And eventually my pregnancy went fine. In the end, I did need to take a lot of more levodopa. And I think it's because I just really did not sleep well, and sleep disturbances, I think you all know that it really has a big impact on your Parkinson's symptoms. So I think that was the deal, because after delivery, and the delivery went fine, it was just a normal vaginal delivery. And I had one night of great sleep because Josephine was really tired as well from the delivery. Then from the next day, the day after delivery, I could already have my dosage. So I was back to normal, actually. So I was really relieved. And happily, the birth outcome was also great, because here you see Josephine and my family, and yeah, we're really happy, and she's healthy. So this is what I would wish for any woman with Parkinson's disease having a wish to have a child, because sometimes you hear about women deciding not to get to have children because of their Parkinson's, because they don't know whether it's safe or not. And I think all women deserve to be able to make an informed choice. Therefore, we have built PrexPark.com. It's an online, ongoing, worldwide registry for pregnancy and Parkinson's disease. Because we just need to collect as much data as possible and as much information as possible from women all around the world. Because, of course, it's just a small group of women experiencing a pregnancy with Parkinson's, but still there must be, yeah, I don't know, more than 50 per year, I think, or 100 in the whole wide world. We should be able to collect at least more data than the few case reports that are out now. So I want to ask you if you know any woman with Parkinson's being pregnant or having a wish with a child wish, please refer her to our website and enroll, sign up. It's an online surveys. The woman herself gets to fill in. One of the other things we did was dive into the unmet needs of women. Richelle and I wrote this paper together with a group of great women, and we looked into literature, what we know and what we don't know up to today about women living with Parkinson's disease. And actually there are so many gaps and controversies that, yeah, it's just, there's so much to do. And the things that we did find out, you can see a little bit in this table. And we also paid attention to the images, because we want to have some images of women and diverse women as well, because so we have made some beautiful images for this paper. But what we found out that what literature learned us, it was that motor symptoms are like women have more tremor dominant phenotypes. We suffer more from facial masking. Levodopa induced dyskinesia is more in women, and also restless leg syndrome. And we have less disease progression. Non-motor symptoms, you see more mood and sleep disturbances, anxiety and depression, fatigue and apathy, pain, and urogenital symptoms, and less cognitive impairments, hallucinations, and all that. Well, and also the psychosocial issues are really a big problem in women. So I think that also points out that the need in care is different in men and women, because we have more psychological distress, self-reported disability, negative self-image, loss of femininity, and we feel less social support. So I think that's a topic that needs attention in care. In our Dutch survey, we also looked at the work-life balance and self-image, and I wanted to share some of our results with you. there were 110 women involved, and the average age of the women in the survey was 51 years old, and the average age at diagnosis was 45. So these women were living with Parkinson's disease for an average of 6 years. And the time between the first symptoms until the moment of diagnosis, I was really interested in that as well. And then you see here the numbers, and we can conclude that 70% of women get their diagnosis within 3 years after their first symptoms. But 30% of women, it takes longer than 3 years. So that's quite a high number, I think. So I think in women, they just don't think of Parkinson's as often than in men, especially in young women. We have looked into employment status. What was your employment status before you got diagnosed? And then we can see that 60% had a part-time paid job, 19% a full-time. Well, you can see the numbers, and this is what changed. So in average 6 years after diagnosis, 78% had a paid job before diagnosis, and currently, so 6 years later, only 38% has a paid job. So I think that's also a really big impact. We asked for a reason of this job change and change in employment status. Well, 21% of women said it's their own choice or free will, but I don't know what that means. I think it's still has to do with Parkinson's. The motor symptoms and non-motor symptoms, well, you can see the numbers. Well, then we also asked the women about their contribution to household tasks and how their contribution was compared to their partner. And then you see that the median percentage of 76%, that 69% of women does more than 50% of the household tasks still. So it's quite old-fashioned. And then we asked about the care for their children. And well, 1/3 still had children under the age of 18 living in their household and independent of having a partner. We asked them what their contribution was to the total care for the children. And then you see that 70% does more than 50% of the contribution, contributes more than 50% to the care of the children. And 62% of women even said that they believe taking care of the kids is mostly their responsibility. Also we asked about self-image and self-confidence, and we asked them whether their diagnosis influenced their self-image, and 42% of women said it has a negative impact on their self-image, and 55% of women feels less self-confident. Then we asked what aspects of their diagnosis influence their self-image, and you can see they could pick more than one topic, and it was mostly rigidity, the tremor, the changes in speech, change in their walking pattern, slowness of movement, and also the masked face. But it sounds logical to me. It's also all not really nice to see or to show. We asked engagement of PD women in research. Have you previously participated in research? It was about 50-50. Reasons why not was like they just got diagnosed, so they weren't really thinking of it yet. They had young children, so they didn't have the time. The travel distance was a problem. They haven't been asked or been informed about the research possibilities, or they didn't match the criteria because sometimes they first needed time, and sometimes they first needed time to get used to the diagnosis, and by the time they felt willing to participate, they didn't match inclusion criteria anymore. So, but promising is that 86% of women would join a research study in the future again. So, and 14% said not sure, but I will convince them to join anyways. So I think no one said they wouldn't. So that's great. I want to show you some of the important resources. I think one of the things I'm quite proud of, and I think every woman should read, is In Her Shoes. We have been preparing In Her Shoes for the WPC conference in Barcelona with a group of women. And it's about, it contains all the information I think women should know about the pills, periods, pregnancy, parenthood, all those things. You can download it for free at ypdwomen.com, and it's already there in 5 languages, and it's being translated in many more, and even in Japanese. So I'm really looking forward to that. I don't know even how to read left to right, top to bottom, but we'll see how to put it in the format, but it will be available in Japanese soon as well. Other important websites, of course, is mymovesmatter.com, but I think Richelle will dive into that. It's a great app that women can download and use to track their hormonal as well as their Parkinsonian symptoms. And I think it's just a great thing because it has been missing. And I think it will be helpful for all women to use. And also pregspark.com, the pregnancy registry. This is my team of researchers. I work for Professor Bas Bloem together with Bart Bos, neurologist, and Milanka is my PhD student. And Hein Bogers is our gynecologist. And in case you want to contact me, this is my email address. Feel free. Okay, that was it.
Thank you very much, Annelien. I think Richelle, you will take over now.
Okay.
There you go.
Oh my gosh. All right, just bear with me 1 sec. Okay. And can you see it there?
Perfect.
Is it
excellent?
The full screen? Okay.
Yes, it is full screen.
Okay, so thanks a million, Annelien. And just to explain, we sort of split presentation between us. I suppose it kind of represents where we are in life in terms of the hormonal stage of Parkinson's. I basically was diagnosed with Parkinson's 7 years ago, roughly, when I actually picked it up myself when I was pregnant with my daughter, 3 months pregnant. So I've kind of gone through the pregnancy phase, the menstrual effect phase. I've gone through perimenopause, menopause, and I'm now postmenopause. So I'm going to focus on that phase in this section of the presentation. So just a caveat is that I'm not a neurologist, I'm not a gynecologist, I'm a healthcare professional, a registered dietitian. I'm a woman living with young onset Parkinson's because that's when I was diagnosed at the age of 47. I'm a wife and mum of 2 kids and 2 pets, and I'm an advocate for my health and that of other people with Parkinson's. So I'm going to just start off in terms of just clarifying, in terms of, to be honest, I probably didn't really, pay too much heed to this myself in terms of, what is perimenopause and menopause until it started to hit me. But just kind of the definition is basically perimenopause is when your hormone levels start to change, but before your periods have stopped. Usually occurs between anywhere the ages of 45 to 60. And during this time, your menstrual periods become less regular and a range of symptoms can occur due to hormonal changes. In terms of menopause, it's once you have not had a period for 12 months, you have reached the menopause. So unfortunately, there is no test at the moment that tells you whether you're in the menopause. There is only the caveat, the statement that if you haven't had a period for 12 months. And basically it can take time for our bodies to adapt to these changes, and symptoms due to hormonal changes can persist. So the menopause symptoms, sorry, the title should have been menopause there, can persist for many years of the menopause. So I just want to, I'm going to present today new data from a survey that I did through My Moves Matter and the Women's Parkinson's Project, of which both I am co-founders, and basically was focusing on the perimenopause and menopause stages of women living with Parkinson's. So one of the questions that we asked is, which of the following perimenopause and menopause symptoms, are you experiencing? So And those women who were postmenopausal, we asked them to reflect back, and the symptoms are very similar. So you'll see here, in terms of the symptoms, fatigue was top of the list, sleep disturbance, urinary urgency, night sweats, flushing, that sort of heat flushing, reduced libido, brain fog, anxiety, etc. And you can see down the list there. And then in terms of other symptoms that people mentioned, the 18% mentioned, other symptoms were joint pain, itchy skin, weight gain, heavy periods, shorter periods, low bone density, muscle aches. What I think you'll notice in terms of all these symptoms, particularly in the chart, is that they are symptoms of Parkinson's too. So this is where it becomes very complex in terms of women with Parkinson's, is defining between what's Parkinson's and what is perimenopause or menopause. So we asked also about perimenopause. Did you notice any impact on your Parkinson's symptoms? So you'll see here that in terms of symptoms worsening, over 30% said that their Parkinson's symptoms worsened during the kind of perimenopause, menopause phase. And 65% said, I'm not sure. And that sort of reflects in terms of, in general, women are not sure in terms of what symptoms are menopause, what are Parkinson's, and, you know, we need to do more research in this. The other thing we sort of said, if around the time of your perimenopause and menopause, so those women who did notice a worsening of their symptoms, what were the symptoms that were worse in terms of Parkinson's? So you'll see here, difficulty sleeping, tremor was worse, rigidity and stiffness was worse, anxiety, difficulty concentrating, pain, difficulty multitasking, longer off periods, depression, and you can see as they go down the list. And in terms of other off symptoms or other symptoms people mentioned were vivid dreams, worse balance, and daytime sleepiness. So these were the symptoms of people, Parkinson's symptoms people felt were worse because of their perimenopause and menopause. So we asked as well, did you continue any form of hormonal contraception during peri or menopause for your menopausal symptom management? And you'll see that 30% said yes, but overwhelmingly the larger percent said no. In terms of HRT, did you take HRT? So again, you'll see the larger percentage said no. But if you took HRT, what age did you start? So some people started quite early, but you'll see the majority are kind of in and around the sort of typical perimenopause, menopause stage. Then we asked, when you took HRT, did you notice whether it had, did you think it had a positive effect on your Parkinson's symptoms? So you'll see 42% said yes, 21% were not sure. So it possibly could be that 50% sort of noticed a positive effect. In terms of other comments in this question, is I tried to stop, but I got so much worse I started again. I felt mildly depressed, the stiffness increased more often, so tired I couldn't work out, and my strength training didn't leave the same positive effect. I had better sleep, no brain fog, reduced fatigue, way more energy, motivation. And on the flip side, one woman said that she felt awful in terms of taking HRT. So this was just to say it's not a panacea for everybody, but it's certainly showing signals that HRT is generally has a positive effect for women as Parkinson's symptoms. We also asked, were you offered antidepressants as an alternative to HRT? So about 19% said yes, because that has been reported as being a kind of common treatment of perimenopausal menopausal symptoms. We also asked, like we did in terms of the the menstrual cycle, we asked, has your neurologist at any stage talked to you about the impact of perimenopause and menopause on your Parkinson's symptoms? And you can see here a whopping 95% no. And this is some of the comments that came back. No interest, nobody seems interested, no, only when I brought it up to them. I've been asked and been dismissed. With regard to anxiety, it's been brought up, trying to get an appointment for 2 years with a gynecologist, can't get in, wasn't aware of menopause. The neurologist said there's no change. They said they weren't trained in the field, so they can't help me. So this is a big issue in terms of this wall of blankness when it comes to women suffering around this issue. Has your neurologist at any stage discussed with you about HRT? Again, a whopping 95% said no. And some of the comments here, only that it's okay to stay on HRT patches with PD meds. I was already on HRT, a diagnosis, recommended I stay in HRT. So there was some positive comments. Other people have spoken to their gynecologist or gone to HRT specialists because they haven't been able to get the advice from the neurologist. On the flip side, some women said it's never been mentioned. When asked the neurologist, he said to talk to your doctor. Some women, we have to be careful, have breast cancer in Parkinson's, so that has to be taken into account. And I just wanted to put in this comment here with regard to gender identity. So someone always said I was informed, I was on the waiting list for gender identity evaluation, and later I was unlikely to be prescribed HRT. So this is an area we have to address as well in terms of transgender community. So the other thing is, did you find it difficult to discuss hormone-related issues with your neurologist? So a good percentage said no. So I think this kind of reflects that really it's more to do with the neurologist not actually understanding, not willing to sort of have that discussion, not being trained in it, not having the evidence to maybe feel comfortable to advise women with Parkinson's. And it says these are some of the comments that came back. I don't feel comfortable talking with neurologists, but I feel that they don't know anything about the impact. It didn't mention the menopause symptoms, and they said the symptoms were, not in relation to Parkinson's. So you can see here quite a trend in terms of negativity around, it wasn't seen as significant or lack of understanding by the neurologists. So the other thing we asked was in terms of nurse care, has your specialist nurse discussed with you at any stage? So again, a large percentage said no. And have they discussed HRT? And again, no. And did you find it difficult to talk with your Parkinson's nurse? So, again, the women didn't have a problem talking, but the issue was that 43% didn't have access to a Parkinson's nurse. So that's obviously an issue because, probably women possibly might talk more to a Parkinson's disease specialist nurse, but obviously if you don't have access to one, then we can't. Have you discussed your perimenopause, menopause with your gynecologist? So you'll see here 73% no, because possibly women don't have access. But again, we need to have a look at this and start to engage more with the gynecology colleagues, like Annelien has mentioned in Radboud, actually bring them in on the picture like you would a gastroenterologist around bowel issues. So this is just some of the comments in general to the survey. I do feel that menopause had and still has a huge impact on my PD, and there's no information available to discuss it. When I've asked about contradictions, I started HRT, felt fabulous. Parkinson's symptoms improved. Great. I recently started pellets after HRT. It helped me tremendously. My personal experience is that I really need HRT to be able to do all the things I do and prevent my Parkinson's getting worse. When I stopped, I felt much worse in my symptoms, and during that time I developed dyskinesia. I've started to take tablets again, but the dyskinesia is still there, but still feeling all better. There was a lady who was 79 who's on HRT, and she basically has continued on it to help with hot flashes that she still gets. And this last lady here was a doctor and said that, she decided to take HRT and she had to advocate for herself. Screen is just stop there. So this is just on the flip side in terms of some of the cons, I suppose. So a lady here took HRT for 5 years, but she stopped due to, she started by a dental cone and she had to stop due to developing breast cancer. Also, in terms, as I mentioned, there are a lot of crossover symptoms between Parkinson's and menopause, is trying to define between the two. Also, there needs to be discussion about possible downsides of taking HRT and its interaction with PD meds. We don't know much about that. There's a quote here: hormonal fluctuations have had a significant effect on my general health, mental and physical, and my Parkinson's. It has taken me close to 2 years to understand those fluctuations and be able to manage them with reasonable effectiveness. And Parkinson's suffered significantly during this time, with medication being random in their effectiveness and duration. To say these last 2 years have been a nightmare would be an understatement. And that's a bit like the menstrual cycle. It's the medication potentially being less effective because of the alterations in hormones. So as this woman says here, it needs to be responsibility for the whole person's summer. I feel like I'm a ping pong ball in the world's longest rally. And the last one, my Parkinson's only recently been diagnosed after years of suffering symptoms are all put down to menopause. It's hard to know which symptoms are Parkinson's or which are menopause. They overlap. It does affect how the medication works and doesn't work. The doctors in the US do not seem to believe me. So there definitely seems to be an impact on the efficacy of the medication in terms of women's experience. So just in terms of another study that was an abstract that was produced by Radboud and Annelien's team that she works with, and it basically corroborates the survey, the results I've just shown, that basically 2/3 of the women they asked who are postmenopausal basically said their symptom severity was worse after the menopause. So their suggestions were that we need to increase engagement with neurologists and adjust treatment if necessary, refer women to a gynecologist to explore hormonal therapy, and raise awareness among women. So the next section I'm going to focus on is sort of key differences in terms of women and things that women who are maybe on tonight need to take into account to sort of take control of their health with Parkinson's. So women with Parkinson's have a higher level of osteoporosis, a higher fracture risk, and tend to lose weight earlier in the disease course. And weight loss is a negative predictor in terms of osteoporosis, but also it's a negative predictor for outcome of Parkinson's, is losing weight unintentionally. So in terms of osteoporosis, you should be screened, on diagnosis. Likewise, you should be screened in terms of your weight, but we know that people are not being weighed by neurologists or sometimes by health professionals. Ideally, refer to a dietitian and physio to help in terms of malnutrition and bone deterioration. The other thing is women with Parkinson's also have a higher incidence of pelvic floor disorders. So again, should be screened for pelvic floor and referred to a physio to help with that. And in terms of motor symptoms differences, women tend to suffer more from tremor, restless leg, facial masking, and more dyskinesia. So I'm just going to focus in on dyskinesia because I think this is a really important difference between men and women. So just in terms of research, there have been no double-blind placebo-controlled study of levodopa was ever performed before its approval by the FDA in 1991. So now you have to do kind of gender studies, etc. So there's a lack of sex and gender impact studies in terms of the medication for Parkinson's. So a study done in 2020 showed that there are sex differences in pharmacokinetics, strongly predicts sex-specific adverse drug reactions for women, but not men. This sex difference was not explained by sex differences in body weight necessarily. Then there was a paper in 2022 that showed the area under the curve and the area under the curve adjusted for body weight were higher for women than men. And that's basically what that relates to is women absorb more of the medication, the levodopa. And so then another paper in 2022 came out saying women might require a 25% reduced weight normalized levodopa dose compared to men to achieve the same bioavailability. And also to try and help minimize dyskinesia. So in other words, Michelle there on the call on the webinar is probably on the same 3 times a day dose as I'm on, but we have different body weights, BMIs, and mechanisms in the body that affect our absorption of the medication. The other thing as well, on the last point there in the Contine paper, was that there was a 20% higher levodopa absorption in patients treated with benzeridine versus levodopa carbidopa, the same 4:1 ratio. Should be kept in mind an individualization of optimal levodopa therapy, especially in patients experiencing fluctuations in motor response and peak dyskinesias. So for women who are suffering from dyskinesias, levodopa combined with benzeridine is possibly not the best combination because it basically is absorbed more and so could worsen. So for example, that would be like a Matapar versus a Cinemat. So in terms of choice of therapy comes down to the type of symptoms and side effects that you have. So again, some of the studies show that adjusting plasma levodopa levels by BMI showed the most relevant. That's your body mass index rather than just your body weight. I think that might be reflective of women's body fat distribution, and that's affecting pharmacokinetics as well. And BMI could be even more than body weight, could be useful to set up the best personalized approach. In particular, BMI emerged as the only predictor of half-life in women and not in men. So just in terms of dyskinesia as well, women, as I mentioned, tend to lose weight more than men. And what happens here, this kind of shows you an algorithm here. So when you've got weight loss, what happens is that you get higher levodopa dose per kilogram. So you basically absorb more levodopa when you lose weight. That can lead to more dyskinesia. Then because of dyskinesia, using more energy and burning more energy, you lose weight. So then you end up absorbing even more levodopa of your dose. You get more dyskinesia, and this cascade goes on. And this is, I think, just from observation as a dietitian and a woman with Parkinson's and looking at the literature, is what's happening in women is they're not been titrated, they're losing weight, and they keep on absorbing more levodopa, they're getting more dyskinesia, and it just is this spiral. So you'll see that there's a higher rate of dyskinesia in weight losers than non-weight losers. Okay, so the non-weight losers, they don't get this cascade. The other thing in terms of pharmacokinetic factors that are different between men and women is the real clearance of drugs is decreased in women because of a slower GN4, which is basically your kidney filtration. Okay, that's your kidneys basically detox your drugs. Women also have a lower gastric acid level, they have lower plasma volume, lower BMI, lower organ blood flow, total body water differences, and all of which affect drug distribution and pharmacokinetics. And responses to drugs are affected by physiological changes during the menstrual cycle, and I would suggest also likely during the transition into menopause and postmenopause. So basically, there are many factors here should be considered when planning care management of Parkinson's in women that are not been looked at and need consideration sooner rather than later. And I suppose the other thing is that the research would show that women wear off more, have more fluctuations than men. So in terms of the reasons why, there has not been, I think it's probably to do with the previous pharmacokinetic factors that I presented earlier. And we need more research because, obviously, 98% of people are probably on levodopa of some description. And it's all about trying to flatten out our fluctuations so that we can ultimately have the best quality of life as we can. And as Annelien said, we're not small men, we're all individual. And it's the same for men as well, as looking at what are the differences in men that need to be looked at and personalized. And just to say that there is such a thing as the menopause, there is the andropause, and there is some research showing that men's hormones, in particular testosterone, are lower in men with Parkinson's. So there's a lot within hormones that we are, we don't know. And I think there's a lot of answers in there. In the hormones across the genders. In terms of non-motor differences as well, women tend to have more, as it was mentioned before, issues in terms of sleep, insomnia, depression, and obviously also urinary issues. And just in terms of, there was a study done by the Val Hebron group in Spain that actually compared the different stages of a woman's sort of hormonal life with Parkinson's, and women who are menopausal and postmenopausal have a higher level of constipation and urinary urgency. So that's a big area that needs to be focused on in terms of postmenopausal women. And in terms of urinary management, I just wanted to kind of, draw your attention to a recent study in terms of urinary continence and self-monitoring. That study showed that self-monitoring resulted in fewer urinary symptoms, and that a multi-component behavioral therapy was associated with reduced bother and improved quality of life. So the factors were using pelvic floor muscle exercises, using bladder training, fluid management, constipation management. And these factors all together had significant impact on improvement of urinary symptoms for women with Parkinson's. And probably would also help men as well, because obviously men do suffer from this also, but women in particular, particularly around the perimenopause, the menopause, and postmenopause. In terms of other sides as well, is this is from another paper that shows the different kind of modifications that can help in terms of urinary management. And one of the key things was topical estrogen can be beneficial in terms of urinary incontinence. I just want to go on the just a kind of a warning. There are certain medications that are used to help with urinary incontinence. They're called bladder antimuscarinics. And they have been, and there are a lot of studies out there now showing that they're linked to dementia. We all know the Parkinson's, there is an element of dementia in it. And these are the particular medications that have been highlighted as being at risk for dementia. So just to check if any are on any of these medications, you should be talking to your doctors about considering coming off them. On the flip side then, there has been some studies on a drug called mirabegron, which actually doesn't have this effect in terms of causing dementia and has had quite successful improvements in going to the toilet regularly. So these are things that you can discuss and ask your neurologist about. In terms of dietary considerations, I just put them in because I find them interesting in terms of some of the differences. So in terms of the MIND diet, there was a study that showed that women following the MIND diet had up to 17 years later age of onset associated with MIND diet in terms of Parkinson's. Elevated homocysteine levels in women are associated with poor cognitive performance. And that's sort of to do with B vitamins. Women experience gastroparesis, which is basically slow stomach emptying. It's 3 times more prevalent in women. So that could be part of the picture in terms of having more fluctuations and more off times. Because basically, if your tablet is stuck in your stomach and doesn't move to your intestines where it needs to be absorbed from, then you're not going to have the effect of on times. In terms of food addiction, it's been shown to be about 24% in a study in people with Parkinson's, but it was higher in women than in men and higher in women than controls, like quite a substantial high level. And also in terms of cravings, it's something that's mentioned a lot of times by people with Parkinson's, in terms of sugar cravings. And all the women here who've gone through hormonal fluctuations will know that, there's a sugar light that goes on when hormones are in play. So that possibly plays into the kind of Parkinson's craving situation as well. The other thing I just wanted to draw attention to is we have done surveys. So our original survey that we did to the PD Avengers led to our paper, which also then led to Sonia Mather, who is on the patient Parkinson's panel for Michael J. Fox, and a number of colleagues whose just names have gone out of my head, sorry, got together along with Helen Matthews and Christy LaMonica and Kat Hill, to put together the survey on the Michael J. Fox website. It's the Insight study, so you can go on and join these studies. And so we had 3 surveys up there, looking at the experience of women living with PD, looking at the hormonal stages and looking at other things in terms of HRT, etc. So the good news from that survey is that overall, most women were receiving preventative care screening, such as regular pap smears, mammograms, bone density scans, routine blood work. Bad news which reflects the survey that I presented earlier, women are not being asked about their menstrual cycles and menopause by the neurologists. 50% of women, in this case, do not bring up the topic because they feel they're dismissed, there isn't time, or the doctor isn't knowledgeable. And also, in terms of corroborating what Annelien presented, self-image is negatively impacted by Parkinson's in women. Motor symptoms have the greatest impact in women in terms of this survey, and that might be again reflecting the fact that women are having more off times and worse fluctuations, and socialization is negatively impacted as well. So just in terms of some other areas, as women suffer from more pain, and this potentially is to do with, it's a bit like depression, anxiety, is potentially maybe affected more by the serotonergic system, of which there is not much Parkinson's treatment at the moment. There are psychosocial differences. The women tend to have more psychological distress, self-reported disability, negative image and some of the things that Annelien already went through. Feeling of not being heard, which I think you can see now why there's a feeling of not being heard, because basically there's a brick wall and they bring up their symptoms. And so women start to downplay their symptoms because you get sick and tired of just being, battered off. So eventually you start, just not saying anything. So as the quote says here, although I realized again, this disease is not my fault, it did compromise my role as a mother of a young child, a daughter of an elderly parent, a wife, and a business partner. I can't let this kind of webinar go without talking about care differences in women with Parkinson's, particularly because, it probably comes in the kind of menopause, post-menopause time where people, have other people to care for. But in terms of care differences, women with Parkinson's are twice as likely to have a paid caregiver. They have many more years where alternative caregiving may need to be arranged because women outlive their spouse. Caregiver accompaniment to visits are lower for women. So men with Parkinson's tend to have their partner go with them, but women tend to not have as many partners go with them. Partly because that is actually seen in a lot of research, but also because there are women who live on their own. Women have a faster rate to using a paid caregiver than men, and more likely to reside in a nursing home because they have lack of access to carers. And also in terms of women tend to, as Annelien said, be the carer for their elderly parents, kids, etc. So anyway, these factors should be considered when planning care and management for women with Parkinson's. So I suppose on that note, it's really important for women in terms of the psychological support, in terms of, getting answers, is to find your tribe. So we know that one of the core things during COVID that impacted people was loneliness, and not being connected has a huge correlation with not doing as well with Parkinson's. So find your people. So there is the likes of Con to Parkinson's. There is a Facebook group called Strong Her. There's the Women's Parkinson's Project. There's the Parkinson's Diva. She's a book that many women have found very helpful. There's a Facebook group called the Young on YOPD Women Unite. There's also Twitchy Woman. They're just a kind of reflection of the different places that you can find support. So I suppose I'm just going to, finish off in terms of talking about, at the end of the day, there's a huge lack of access to care for many of us, men and women with Parkinson's. And that is because there's a lack of access to neurologists and health professionals. So in terms of the paper that Annelien and myself wrote with Indo-Subramanian and Professor Elena Morrow, we identified that we needed a way for women to be able to track their symptoms, to be able to basically prove what's going on because they were being dismissed so much. So this is where this app came from originally. I was asked to take part in a digital hackathon, and basically I brought the idea saying, look, we need to develop an app that can do this tracking. And we won the hackathon, and with that money and subsequent programs that I've been on that I've managed to get grant funding from, we've launched the app. It's on the Apple Store and the Google Play. It's free to use. And actually, it's not just for women, it's for men, it's for anyone with Parkinson's can use it. Allows you to track your medication, has a reminder, you can track your symptoms. Obviously for women with menstrual cycle, they can track their period, but also for women with menopause, within the symptoms, there are menopausal symptoms as well that you can sort of track. So just showing you here, very basically, that it shows you how you can add your medications. It has hormonal therapies in there for women with Parkinson's. It allows you to predict the severity, the timing of your symptom. It allows you to also show you here. So it shows you can see the symptoms across the day. You can track your period in terms of severity, and you can also add a note to it in terms of what's going on for you in that particular day. So just showing here in terms of you might be feeling extra wiped out or whatever, and it tags it to your symptom. You can add journal entries. There's video, voice, and text, because we all know with Parkinson's it's sometimes hard to engage with the mobile. This is what came through in the research focus groups. So it allows you to actually, to reflect. So I was able to track my own symptoms, say in micrographia. So you can then correlate between your symptoms and your period and your medication intake. So you can sort of see the correlations. So I think that is it. And then in terms of just showing you here, the idea is about trying to improve our medication adherence, because one of the biggest problems is people don't adhere because they don't really understand their medication times around food, etc. They don't notice the difference in terms of their period affecting them. It's about when you crack something, it helps you to make behavior changes, and also helps you to share decision making with your neurologist, because if you don't have the information, it's very hard for them to make the treatment changes. And ultimately, it's about increasing your self-efficacy and confidence in managing their condition. So this just shows you when we did a survey, we've done focus groups, workshops, interviews with neurologists. Some of the key findings were that 62% specifically was women forgot or sometimes forget to take their meds. 78% want more ownership of the condition. 91% want to reduce the fluctuation of the symptoms. 97% want to understand that their symptoms relate to the medications. 89% want a symptom severity summary to be able to show to neurologists. And 93%, I think this reflects just the great work, that those Silver Bullet are doing in terms of people want answers through research. And in terms of digital app, these are the kind of top 4 areas people wanted: symptom tracking, expert information, research studies, and being able to look at the symptom fluctuations. And this is some of the user feedback: being able to see the meds and symptoms in a calendar view, being able to merge Parkinson's symptoms and menstrual and menopausal symptoms has been so helpful to discern a pattern. And in terms of journaling, being able to log a little bit more about what's going on, and particularly if you're having tremors or dyskinesia, you can't hold the phone as well to type. You can do a video or voice to text or a voice log. And just to finish off, we have applied for a grant application to do a pilot trial of women in Europe tracking their menstrual cycle of Parkinson's across their menstrual cycle. So we're waiting to hear whether that we'll get that. And also we've applied for a grant, again, looking at women with their Parkinson's and menstrual cycle symptoms through France Parkinson. So we're applying for a grant there as well. So trying to do more research. So that's it.
Annelien, Richelle, thank you very much. Annelien, thank you very much. Also, both of you have taken us through a wealth of information tonight. I think we should all agree that actually there, of course, were many women who are already in the shoes of a woman with Parkinson's, but tonight you just helped them understand how other women are feeling and comparing their own situation to the rest of the female population. The great shocker for me is the total absence of understanding and advice from the neurologist. There's a real gap also in research, obviously, that you're trying to plug. This leads me to the first question from George, who basically is from, for those who don't know George Ackerman, George is the son of Sharon from Together for Sharon. So George is asking us, how can we gain more awareness for women with Parkinson's? How can we change this situation where women are being seen as little men and where even mice are male? So how do we change this? How do we move from an unacceptable situation to progressively a slightly more acceptable situation?
I think with webinars and events like this, the WPC, we've been getting attention to this topic. There are more and more researchers involved in the world trying to dive into this. The book Inner Shoes and sharing this with other women, that's all very important and helpful. And I think we have created a sort of momentum, and it's kind of rolling. It's like a snowball. It's becoming bigger and bigger and bigger, and we're not intending to stop. So Richelle and I, they're all other energetic women having a really much passion about this topic, and we're on the roll and we're not going to stop. So I think it will get more and more attention in the next coming years, and we will get there.
Just to come in on the back of that, thanks for the question. I mean, it's like Together for Sharon, he's done interviews with myself and other women with regard to Parkinson's. So it's doing things like that. You guys do the webinar, but I think I went to the Movement Disorder Congress as a health professional, and I was really quite shocked how little knowledge there was about. I got up at every session and asked about gender. And, it was almost like an embarrassing kind of silence. And then, yeah, that's probably, we probably should do that. You're going, okay, 50% of the women in the world, actually 51% of the people in the world are women. And you're thinking, this is something we should, yeah, that's a good idea. And also just in terms of women percentage. So in the Western world, it's 60-40, but actually in Japan, for example, there's actually a higher percentage of women with Parkinson's than men. So there are differences globally, and yet this is not being really investigated. Also in terms of, so what I would say to people here is, you know, any research that comes across your table, you should be checking if there's a gender. We should be asking all researchers to include gender, whether it's in lab research or whether it's in clinical research. It should be on the table. And I think also it's also really important that men ask for it as well as women. And I think the reason for that is I think there are potential answers in women's bodies for all of us in terms of developing drug therapies or care treatment pathways or whatever. So I think it's to benefit all of us. So it's really, you know, advocating for women is going to benefit us all.
Men should read in their shoes too.
Yes, this is actually an amazing point you both are making, that this is not just about women. It's by understanding the differences affecting women, we maybe understand PD better overall for men and women. So this is really critical.
Yes. I think there's a gold mine of data in research that has already been done, but we can dive into and look for these differences. I think there's a lot we can learn from research that is already there. Yeah, I
agree. So Donna is asking about how should women be taking levodopa as their weight and BMI changes? And she says this is the first time that this has been talked about in a webinar, and she's very thankful. Can we perhaps, one of you could perhaps clarify the difference between weight and BMI? Or you calculate your BMI, and how do you basically manage the change in BMI?
I send a website in one of the answers in the Q&A where you can measure your BMI.
Thank you.
So it's basically your weight in kilograms divided by your height in meters squared. So, and I say the research seems to indicate that the BMI, and I think it is because it's to do with, you know, body fat distribution of women, possibly affects the absorption. You know, it's probably one of the parameters in there. But the problem we have is that, as you know, with, for example, the likes of Cinemat, is that it's very hard to titrate it because there's only one type of tablet. So, but actually interesting, at the Movement Disorder Society Congress that I was at, there was I don't know, it was a Norwegian or Swedish company that actually has developed a tool that has little beads of levodopa. There's small little beads that you can actually titrate very small amounts, and you can titrate it exactly more personalized. So I think that is kind of where it needs to go. It's a bit like diabetes and insulin management. You know, we need to kind of get more subtle in our you know, use of levodopa would be my thoughts on it.
Thank you. I think that we should definitely look better from a research standpoint at BMI versus levodopa dosage, because at the moment I have never seen a neurologist asking me what my BMI was to determine how much levodopa I should get. You get like the blank check at a certain milligram dosage being given to everyone quite blandly, I think.
Mm-hmm. Actually, this is a very important point, because most people, because I did research in terms of nutrition with people with Parkinson's, most people with Parkinson's are not asked or asked about their weight by their neurologist. So that is a big impact in terms of if you've lost a lot of weight and you don't tell your neurologist, or they don't pick up on that, that is going to be affecting your symptoms, particularly for women, as I mentioned, but men, it can happen as well.
Yes, of course.
Changing topic entirely, sorry if you don't mind. Someone is asking about Botox injections for bladder incontinence. And does it have an effect on dementia? This is a bit a topic I've never heard about, but actually I don't know, Richelle, if you've ever heard about Botox treatment and dementia.
Well, I mean, Botox is used for dystonia, so I would imagine it's not. You know, I think we'd know about it if it was linked to dementia. So the drugs I mentioned were mainly to do with tablets that are taken for urinary incontinence. So I think the Botox is
just a local injection. I don't think there's any link.
I think it's no, I don't think. I think the Botox is probably fine.
Mm-hmm.
So there's another question about the DBS versus men and women. I don't know whether that topic, I guess it's never been researched, but
no.
Is there a difference in response to DBS for women and men? Yes, or is there?
Response?
So no, not in terms of response, but in terms, well, actually, I think there is beginning to be sort of research around it, but in terms of access to DBS, women get less access to DBS than men, are not referred as often. And when they are referred, they don't go ahead with it as much as men. They haven't asked women why.
General anesthetics.
Yeah.
That will help.
Yeah, I think women prefer to have it asleep. Is that right, Annelien, than awake? But my own theory on it is that women possibly are more risk adverse to, you know, such a sort of treatment. And actually, it was really interesting in the Movement Disorder Congress as well. There was a presentation with regard to device-aided therapy. So, like, you know, Geodopa, what's the other one? Apomorphine. But actually, there's a new drug coming down the line called phospholipidopa, which is, I think it's AbbVie, and it's looking very exciting in terms of helping fluctuation. And I think that gives I was very excited, particularly from a female perspective, in terms of helping around menstrual cycle and hormone fluctuations. It really seemed to help even fluctuations. So that's coming down the line early next year.
Is it AbbVie, ADVIE?
It's AbbVie, ABBVIE. So AbbVie is the company, and the drug is called phospholipidopa. So it's actually going to be, instead of like carrying a big pump like you would a Geodopa, it's actually it's not it's subcutaneous, but it's not delivered into your gut, so it bypasses the gut.
Oh, I see.
So there was a lot of interest in, particularly, as say, in terms of women and hormonal fluctuations. I thought it looked very interesting, and also having an option instead of DBS. You know, it's the only option.
Thank you very much, Richelle. Another question from Donna, who is asking whether women are more sensitive to immediate release levodopa and would therefore be only on extended release levodopa.
I don't know the answer to that. I say not a neurologist. In terms of, I think, you know, it probably comes down again to the individual person in front of you. You know, I think there's specific reasons why neurologists would pick immediate release over controlled release. I mean, in terms of immediate release, my understanding is that, you know, you'll turn on within up to 40 minutes. Controlled release, you know, is a longer period of time. So it's like 2 hours, I think, Annelien, or 2 to 3 hours. So,
but is it known that women take more extended release levodopa?
I don't know. It's a good question. I don't know. And I don't know what the impact would be in terms of absorption rates.
Everyone I know just uses the fast one. I'm not aware of this.
But it's actually an interesting question, because perhaps
could dive into it.
Yeah, it could be that maybe the immediate release is giving women too quicker, and it doesn't. I don't know.
Fluctuations. I don't know.
To be asked. You'll ask the question.
So there is no lack of new topic for PhD students in the future.
Absolutely.
No, not at all.
Men or women.
I think I think the pharmacokinetics in women would be a really interesting study.
Yes.
But it's not been done.
So just a couple of comments, which are not questions, but someone anonymously saying, and then there are those of us who are alone.
Yes.
And I just wanted to stress, of course, that actually the loneliness is a very big predictor of a negative outcome of Parkinson's progression, based on people like Laurie Mischke studies. Are you covering that as well?
That's why it's really important to connect in with, you know, the likes of the book, the likes of the support groups. It's really important to not be alone. And there's many women in these groups who are living on their own
network.
Get that support network, and also, you know, to talk with your friends and family, and so there's a paper done by actually Dr. Indra Subramanian with gotten Bradley Daniels with regard to stigma, and it was shown, and we know with stigma women suffer from it, you know, a lot. But the people who suffer from stigma and tend to isolate more, and also then don't actually get access to services much. So it's kind of definitely linked in with being, you know, on your own. And so it's important to try and to you know, the more you tell people, the more support you get, and the less alone you'll be, basically.
Yeah.
So Tinsy is asking a very important question too here, which is do we have any ethnic minority background women involved in your studies? I know that you had a slide with clearly referring to ethnic minority women, but actually, how actively has it been introduced in your research so far?
Yeah, so I would say in terms of the menopause study I did, it was predominantly white. There were some other ethnic groups in it. What's quite interesting is that, and it's something that I'd like to delve into more, is that women of Black or Asian ethnicities actually suffer worse menopausal symptoms than white women. So there's something going on there. That's generally in terms of menopause. So that obviously has then a knock-on extra effect in terms of Parkinson's. So it is definitely something that I think needs to be addressed more. But we kind of need, you know, I think it's really important that we get people within their own communities to really drive this research, because people respond better to that than me sort of doing it, for example. So I know, for example, Denise Coley is doing some great work in terms of the Black women with Parkinson's and a support group, and trying to drive research on that side. So I think that's a really important area that has to move forward more.
Thank you, Richelle. Anne is basically asking if there is any research regarding the number of women diagnosed with PD around the time of menopause versus men of a similar age. So do women get more or less diagnosed around menopause versus other periods of their life?
Well, I'm not sure, but I think I get where the question comes from, that menopause symptoms are much similar to Parkinsonian symptoms, so it's really difficult to differentiate. And what I hear from many women is that they have been struggling with their perimenopause, and then eventually it was Parkinson's after a couple of years. It hasn't been menopause, but the Parkinson's, but they didn't recognize because it's so mixed up. So I think in women during perimenopause, getting a diagnosis of Parkinson's disease is quite difficult. So that's not the highest, at that age group, it's really a difficult diagnosis to get. And I think it takes longer, but I don't have the evidence, but I can just imagine, and of what all we have heard and learned, that it's a difficult phase. Yeah. But you can use the app of Richelle. Yeah, but then you already know you have Parkinson's, but it's really difficult to differentiate, even in the app.
So in terms of, you know, obviously women are diagnosed more postmenopausally, because basically what happens is, you know, we've lost a lot of the estrogen. So that's, you know, when symptoms really are bad. And in terms of just the app for women who have Parkinson's, what it can be useful for is actually tracking how you're feeling, to have that discussion around treatment. So whether it's HRT or whether it's non-HRT options, you know, because some women won't want to take it, some women have reasons where they can't, maybe in terms of cancer or heart issues, which allows them to actually say, look, I'm really struggling, it's making my Parkinson's symptoms worse, I need you to help me do something. So other things that can help are meditation, yoga. You know, there are some other non-medical things that can help as well, but it's allowing people to actually share, say, this is what's happening, and I'm, you know, the videos can be really useful because you can show how bad your dystonia is, or your tremor, or, you know, around your menopause or your menstrual cycle.
Good. So I think that actually, I'm just looking at the questions. Yes, well, it's not the detailed question, but Caroline, I just downloaded your app, actually, Richelle. And she basically takes, she says she takes 2 Ritari in the middle of the night, but she doesn't see how to add these dosages in the app. So, sorry, it's a bit of a specific question. I didn't want to be ignoring it.
Okay. Well, if Carolina wants to drop me an email, so it's Richelle@hormonalsmatter.com, I'll answer there like that.
And maybe to conclude, a question by Emma, who is asking, but this is the question that is not so much PD related, but more, oh, sorry, I do apologize for that. No, it is very much PD related. What is the best type of HRT for women with Parkinson's? Patches, gel, or other?
I wish we knew. There's so many types and ways of HRT that has been tried, and in many different periods and many different time frames or durations, and they all are the outcome is all controversial, or how do you say it? They all says other things. So we just don't know. We need to do some proper research in the future to give you answer to that. Yes. So also lots to do on the HRT part. So, yes.
Kerry raising her hand, saying that we have another question that purely accidental. Kerry, I do apologize. She has asked her GP if she can have a full hysterectomy to help manage her perimenopausal PD symptoms. She says that she's okay during the estrogen stage. You can see that actually it's probably a question for you, Annelien.
Yes, I asked her whether she would also have an ovarectomy, but that's what she means. I'm never a fan of a full, complete hysterectomy because it will give you other problems like pelvic floor issues, and also it's like an abrupt, complete stop of estrogen level, estrogen supply. So I would never advise you to do such a big surgery to get your hormones stable. I think you should just visit a gynecologist with more knowledge to give you some proper advice. Yes. But I wouldn't advise to do this, no.
Annelien, as you see the questions, as we both see them, you can see a question from Erwin asking recommendations for the type of communication with her gynecologist.
Yes, yeah, you could, I would visit a gynecologist and discuss this, and HRT can be give you lots of relief because when you have Parkinson's, all your physical complaints and other issues, even when you just have a cold, it can impact your Parkinson's. So being perimenopausal, all the physical issues will also influence your Parkinson's. So HRT can be of great help, but you should just try it just individual. But it can really get you through this life phase much easier. So yeah, but discuss it with your gynecologist. It's a good idea.
And a last question, actually, Richelle, you mentioned those little levodopa beads that allow for a more precise dosage of levodopa. Someone is asking whether those beads are already available or expected to be available soon.
I think they're only in, I think it was Norway or Sweden. I can share it with you, Michelle, so you can do one of your webinars on it, because it's actually quite interesting. Or one of your social media posts about it, so I can look up the information. I have a video of it that I can share.
Thank you very much. And for the person, yes, sorry, go ahead.
I just see there's a question there about breast cancer.
Yes, that's right.
So just with regard to that, there is some research that show that women who have vasectomies, which is where their ovaries are removed early, have a higher risk of Parkinson's, and are often put on HRT to mitigate that. So I think there's unanswered questions there with regard to breast cancer, and obviously not being able to go on HRT and Parkinson's. I do think that is something that needs to be explored. Yeah.
Thank you. And actually, I keep saying this is the last question, but actually I don't want to ignore this one, given that you are a dietitian, actually, Richelle. The last question for the night, and I promise this is it, because actually we have to stop at some point. But is there any diet recommendation specific to women?
Chocolates.
Strawberries.
Yeah. In terms of at the moment, no. I mean, what I would say is what we're trying to go towards in sort of nutrition across all conditions is kind of personalized nutrition. So based on person in front of you, whether it's a man or woman, their age, their weight, so that's what would be specific to the woman in front of you, so there's no particular diet that I would say that's better for women than men. The best diet is the diet for you.
Well, thank you very much. And by the way,
food we love can make happy hormones, and then
absolutely, yeah,
exactly.
But the only thing is, obviously, yeah, that's the thing is, the chocolate is it's tying into our need for dopamine. So it's kind of, there's a number of reasons behind why cravings and sugar are quite big in Parkinson's, but that's another talk.
I don't have chocolate here.
We'll be able to cover nutrition in December when Baz Bloom actually will be joining us for a special session on nutrition. I'm looking forward to that.
But you really need to have a dietitian on at some stage to talk about that too.
So we'll definitely ask him the question. We'll ask Baz, don't tell him in advance actually, Annelien. We'll ask him if there is food that is more recommended for women, and that will basically probably take him wrong food. Well, thank you both for making yourselves available tonight for a great session on being in the shoes of a woman with Parkinson's, which is the case of many people online tonight. I think that you basically highlighted a series of very important points, and you really helped us understand the current situation and really to cover a topic that is very seldom covered, where there is a real need for more information. So thank you both.
Thanks for having us on.
And
yes, thank you very much.
Spread the word.
It was nice.
And before I let everyone go, I just wanted to mention that our next session will be taking place on the 13th of November, when we will be hosting Dr. Wayne Markman, the CEO of a company called Symbix. And Wayne will be talking to us about laser and red light therapies, a topic that I know is very interesting for many people on the line. So thank you all, and I wish you all a good day or a good night, depending where you are in the world. Goodbye.
Thanks a million. Thanks for joining us.
Bye-bye.